My name is Andrew Coe. I'm one of the neurosurgeons here at the University of Washington. I'm an associate professor here with the Department of Neurological Surgery. I'm co-director of the Regional Epilepsy Center. That's actually over at Harborview. In terms of what I do, most academic neurosurgeons have sort of subspecialties. So within the realm of neurosurgery, we often will focus on a particular area. My specialty is functional and stereotactic neurosurgery and epilepsy. Practically speaking, a good portion of my practice would also kind of fall under general neurosurgery, so certain types of brain tumors, some spine surgery, not as much as most, but kind of everybody ends up doing some of that. In terms of how one becomes a neurosurgeon, obviously you go to medical school, so there's 4 years of that during your medical school training. Most people in their sort of third to fourth year during their clinical rotations decide they have an interest in a particular field. For something like neurosurgery, generally it's a fairly competitive residency, so once you're done with medical school, towards the end, you apply to residency programs. For the most part, before you apply, you've sort of talked to the folks at your home institution. So I did my medical school at the University of Illinois in Chicago. There's a Department of Neurosurgery there. You do a rotation usually at your home medical school where you are on the service for a month, 2 months. But most folks these days will just be sort of involved in the department. And so our department, for example, has an undergraduate summer research program for undergraduates. And depending on various things like, luck, you decide, oh, hey, this person was nice, I'm going to work in their lab for a bit. You get sort of involved in the neurosurgery program, but the formal things that you do are a rotation in your home program. You'll usually do away rotations, so you can sort of, after getting somewhat involved in your home program, you talk to the faculty there. But you'll do these away rotations, usually for a month at a time. I mean, there's different types. You have different types of days. So, I mean, you're seeing morning scrubs today. So today was an OR day. So there's days where you do surgery. There are going to be days where you see patients in clinic. And so we're trying to decide if somebody needs surgery or they come in with a particular problem, and you're talking to them about what options are. Those are usually kind of two separate days. There are, for the most part, neurosurgery, especially at the University of Washington. The sort of academic and administrative side of things, you tend to do on nights and weekends. You're supposed to be budgeted FTE. The whole process of how people get paid is very bizarre in medicine. But you do get time, or you should have time set aside for administrative duties. From the service management side, it's talking to the clinic manager, saying, okay, well, we have this many nurse practitioners, we have this many nurses, who's working which days, oh, this person's out on maternity leave, do we need to hire somebody? So that kind of just day-to-day administrative stuff you kind of do during your day. So during most of this stuff are clinic managers and service line administrators and things like that. They're in clinic or in particular part of the building between patients. You might say, okay, well, I have this much time at this point of the day, usually either before or after your clinic. You'll say, let's set up a meeting for 7. So like a typical day today, I had a meeting at 7 to 8, OR starts at 7:30. But for a lot of our cases, there's a patient going out of the room, getting put to sleep. We have residents here, so they're down there sort of like, okay, these things need to happen before the actual surgery. When you do your surgery, there's varying kinds. They take various lengths of time. You kind of know, right? I mean, okay, I know this surgery takes this amount of time. The OR knows how much time these surgeries take on average. So you set up your schedule to do 2 or 3 cases for the day. And then if you have other things that you want to do, for example, this 4 o'clock, I usually OR days like 7:30 to about 7. And so today happened to be a shorter day. We were talking about times to meet. I'm like, okay, well, I'll probably be done around 2. Meeting at 3, another meeting at 4, got a meeting at 5. So like you just kind of fit stuff in like that. But for the most part, you're dividing your attention between like taking care of patients, doing administrative stuff, and then when you fit in your academic stuff is, it depends on the type of career you're chosen. Some people are more clinically busy. Some people focus more on research and academics and things like that. But there's not necessarily a typical day, but there's just things you want to address during the day and night. I've mentioned kind of how long the pathway is to get to where people are. I think kind of no matter where you are in the process, you have undergraduate, you have medical school, you start your residency and you're 4 years in and you're like, wow, it's a lot of time. Folks get pretty old. I think part of the benefit, part of the reason that path is so long is to try and reduce the amount of stress. The challenge is, there's a lot of different disease states we treat. It's very high acuity. If you do something to somebody's brain or their spine, you can kill them, you can disable them. Disabling them could be worse. There are a lot of things that you worry about doing wrong. There's a lot of things to learn in terms of, how to do it. So physical performance of the thing, not the types of things that you're doing are not stuff that you're going to do any other time, right? So it's if you're like a baseball player, you start playing baseball as a kid, right? So you have all this muscle memory from when you're 6 and 7, and you kind of develop that over time. You're not really learning surgery ever, right? And so developing those skills, there's stress involved in that. Can I actually physically do this? There's the stress of decisions, like should we do something or not. There are certain types of neurosurgical conditions where time is a factor. So people with traumatic brain injuries in a car accident, if they're bleeding into their brain, there's a certain amount of time that you have to treat them and be able to do things all right. There are just a lot of different things you can do to try to minimize the challenges of doing that. I mean, the goal is to make it less challenging. So to a certain extent, when you ask a question like that, well, how do you deal with these challenges? Well, the point is to make it not a challenge. And so a lot of the time you spend getting to this point is to try to get so that you're not stressed about things that you're going to do every day. That said, you still always stress about it because it just is, right? So I think being comfortable with that sort of paradoxical mindset is something that people have to be comfortable with. I think there are a lot of people who would just be like, well, I don't even understand what you're talking about. And I think if you don't, then you're probably not going to want to do this. But there's other people who kind of just do it and they don't think about it that much. I probably think about stuff a little bit more than a lot of other people. But it's, when you are in those, the goal is kind of balancing being ready to deal with a stressful situation like that, but not dwelling on the fact that you're potentially dealing with a situation like that. In terms of medical applications of technology, there's a probably good 10-15 year lag between stuff that people think about doing and actually implementing them. Faster computers, right? So there's a lot of different things that we do that, especially in my particular field, basic things like computer-aided navigation. So when I started training, wasn't always used, but basically technology to say, okay, I have this MRI, so I have a picture of the patient's brain. Let's say they have a tumor and you want to take it out. Most brain tumors obviously look different from brain, and so one way to deal with them is you get access to the brain, so you make an incision, you take off a piece of skull, you open the covering of the brain, you can kind of look for it. You're not pawing through stuff looking for it, but okay, well, it's probably here given certain landmarks, and we're going to go look, and okay, well, there it is. Okay, well, where does it stop? There's different things like that. Computer navigation has been around for a while, but basically what that does is you get a little pointer, and you can point to parts of the brain. There's a camera tracking system of some sort that's been registered to the MRI, and you can say, if I'm pointing at this thing on the MRI, that's what I'm pointing at. The types of things you can do to MRIs to process the data to get you information about which parts of the brain are connected, or if I have an MRI, most of the time everything kind of looks the same on the MRI, certain parts of the brain are gray, they're white, they all kind of look the same on the MRI. There's image processing that you can do to kind of break the brain up into different targets. So like if we're looking to implant a device to treat Parkinson's, there's kind of two canonical targets for this, subthalamic nucleus, globus pallidus internus. MRIs are higher quality now, partially because the computing power is better, superconductors are better, all that kind of stuff. That kind of sort of incremental improvement in technology changes how we do things a lot. The ease of it, the reliability, the things that make things safer have changed a lot. CT scanners in the operating room, so if you're implanting a wire, it used to be you'd implant the wire, like I really hope this is the right spot, close everything up, go to the CT scanner, double check. And like, I guess close enough, we'll see how it goes. Or, nope, we're gonna have to go back to the OR. There's a CT scanner in like every, well, not every operating room. There's one that you can wheel around from OR to OR and you can do it there. The patient's still in the operating room. You haven't like closed everything up. It's faster. You're not gonna have that situation where you're like, I wish it was 2 millimeters over this way, but it's not terrible. Let's see how they do. You don't have that situation anymore. You can be like, look, I want to move this 2 millimeters over, and you do it. So things like that, they're more incremental, but a lot of the basic, like underlying theoretical principles are the same. In terms of technological advantages, I think, or changes that have influenced how we do it, a lot of it is along those lines, more for safety, repeatability, avoiding complications, things that people really like to hear about that are like, oh, this is so freaking cool. Neuroimmunotherapies, like stimulating the vagus nerve to treat rheumatoid arthritis. That's not like an area I work in, but I'm part of clinical trials doing this. But that's kind of like would not have thought about doing that. Oh my God, it actually does something that's really kind of cool. So there's a trial ongoing for that. It's a new device, yes, and again, it's like an incremental thing, right? So vagus nerve stimulation's been around, again, since the 90s. We used it to treat epilepsy. In the early 2000s, they started using it to treat depression. They were pretty good for that. This other, again, the application I'm talking about, a few years back, people thought, okay, well, rheumatoid arthritis, there's TNF-alpha blockers. They're immunomodulators that are drugs that aren't particularly specific. Like you could, repurpose this drug for all sorts of sort of autoimmune problems. Get a bunch of side effects, doesn't work for everybody. The vagus nerve stimulation thing about it that's interesting is like not really a whole lot of side effects related to the treatment. The surgery, yes, there's risks and potential side effects to the surgery, but it used to be the seizure devices are this wire that you implant in the neck around the vagus nerve. It's kind of got three little springs. You wrap around the nerve, run the wire to a battery, and it's kind of like a pacemaker here. The device we're trialing for RA is like the size of a really big multivitamin. So it's this thing that you put on the nerve. There's a little plastic thing that kind of wraps around the nerve and holds it in place. That's it. It's rechargeable. You don't have to go you're not putting a big battery pack in. So that's kind of a different application of like the nervous system that I think is pretty interesting. I think, again, at the risk of sounding curmudgeonly, like a huge change is how isn't necessarily unique to neurosurgery, but and there's good and bad to this. So if I'm making it sound bad, I don't mean that. But like electronic medical records. Yes, we had them when I was a resident, but we also had paper charts, and so like you would, in certain ways, it was way more efficient. You didn't have to log into Epic every time you wanted to do something, because that takes forever. The EHR we had back then was called CIS, Computerized Information System, or something like that. But it was like super fast. You go in, you log in, you like type your login, you hit enter, and the thing comes up, like literally. There wasn't a ton you could do, but like, if you click on, there's no like icons and stuff. It was like basically like a spreadsheet. If you want a temperature, like you click on it, it'll put up a graph of like the last one. Like, and it was like, boom, it would just happen. I don't think it stored a lot of this data. Like there wasn't a Microsoft Access database behind it that was, I'm sure Epic is based on, these big relational, like how I can query whatever and get all this stuff back. That stuff probably didn't exist for that system. It might have, I don't know. But it was just super fast. And so if you wanted information on rounds, you Like there's a limited amount where you can just get it super fast. And so when you go and see all your patients in the morning, when I started to have about 100 patients at Harborview that we would be seeing, there's like 4 of us, and we just go to every patient's room, I'd log in, get whatever information you need, you examine the patient, come up with a plan, write your note, like patient is following commands, they blah blah all this stuff, you write it down in our horrible messy handwriting, but you just be able to just do it all then, and then you're kind of done for the morning with that patient. Now people come in even earlier, like we would start at 6. I wouldn't do what we call pre-rounding now, which is like some of the residents will come in, log into Epic, and be like, okay, what happened with all the patients overnight? I clicked on this one patient, I'm gonna look at the nursing notes, what happened, I'm gonna do this, I'm gonna like then copy it onto another sheet of paper so it's accessible when I round, because you can't get all of this in any sort of meaningful or reasonable time period in front of the patients, like in the patient's room. Whereas we used to be able to like, well, I don't need to know what their Tmax was overnight, because I'm gonna go in the room, I'm gonna log in, I'm gonna hit the little button for the temperature, and it's gonna tell me what the Tmax is. Like, I will just do it then, and I will call out, Tmax was 38.4. Their sodium right now is, last check was 134. You know, like you can just do it all there, and you kind of trust yourself, like, as I'm looking through this, I'm gonna make sure it's all okay. Now they'll come in an hour ahead of time, copy it all down to another sheet of paper, maybe forget which things they look, you know, like there's just, it's a different mode of doing it, and a lot of it's influenced by the fact that like the EHR takes way longer to like run. You get a lot more information from it, like you can look up, oh hey, the nurse gave me this medication, this, actually the other one would do that too, but like, you know, there's a lot more information recorded, but sifting through it takes forever. When I get a referral now, like you get this note from the other doctor, and half of it is like insurance information, half of it's copied from the last 90 notes that the person had. You get a stack of papers this big, which they still fax, even though it's all in the record. Like, and you're just going through all this stuff, and most of the information you're tossing out, right? So that changes a lot of what we do on a day-to-day basis, just in general, I think, for all people involved in this. So I think in like the daily practice and how we spend our time, that's probably been the biggest change. Are there benefits to it? Yeah, sure. I mean, billing is easier, I guess. They do track every time anybody accesses it or changes it. You don't lose the, you know, before if I wrote a note and it got like put in the patient's chart and the 3-ring binder, like it tore out, it fell out, like it's gone forever. Like, that never happens now. You can always read it, you know. May not be accurate, but you can read it if it's copied from before, but if somebody can't read your handwriting, you can't tell, right? So like things like that is, you know, I think in terms of safety, in terms of like tracking what happened, being able to figure stuff out afterwards, it's probably a benefit. But does it make it easier to do your job? Not necessarily. What other changes? The other changes I've kind of mentioned, you know, a lot of this stuff does make things more reliable, repeatable, and that's kind of, in this profession, that's what you want. Like if you did something, you want it to be the same the second time it happened. You did it, right? I think just the fact that it has become somewhat of an emphasis is like a big change. I think two things that I've noticed. So when I started residency, one, we have fewer residents, but right now our program is, so neurosurgery in general, I think if you look at like male-female percentage, just looking at that, I think it's like 10% female and 90% male or something like that. My residency grouping, we were 2 residents a year. When I started, there'd been a bunch of sort of drama at the University of Washington that I'm not going to get into it, but if you people know, they know what I'm talking about. And so several of the residents have left, but in terms of the proportions, we were 2 a year. Back then it was an 8-year program. I think the number of female residents was like 2 out of the 16 or whatever. Now I think our residency class, if you, I don't know if this is visible, but if you count them up, it's like slightly over 50%. So that kind of change, you know, was deliberate, obviously. And it has changed the character of the program in a bunch of different ways. the sort of just locker room nature of within resident conversations is definitely different. It's, you know, even now with like 3, we just went to 4 a year for residents. That's, you know, I think we have 23 right now. That's really small compared to other medical specialties. So the groups are pretty tight. A big source of resistance to increasing the number of women or certain minority groups or things like that kind of stems from that. So, you know, you have these small groups. If you start to change things and 1 or 2 people aren't like the other folks, it's, you know, the dynamics of things change, and there's going to be people resistant to it. But you know, I don't think it's different from any other social situation where you're trying to alter the composition of a group, right? If you look at sort of social sciences and kind of what it takes to go from like, hey, you're the token woman, you're the token, you know, LGBTQ or whatever, basically the magic number is like around 25%, right? So once you shift past that, the group dynamic changes from focusing on that person and how they're different to like, yeah, okay, well there's so-and-so, you know, it's Frank, right? So that, I think, is one thing where because it is a smaller group, on one hand it can be harder to make that change, but also easier because just the actual numbers that you have to like change are smaller, and that's, I mean, that's a big deal. Not a lot of people necessarily want to go into neurosurgery. Again, just absolute numbers wise, I think the number of programs in the U.S. is like 270 or something like that. A lot of them are 1 or 2. So like if you think about how many people go into it every year out of medical school, it's not that big of a number. So again, on one hand, it's like we went from 2 to, you know, 14. Okay, well that absolute difference is not that. That's 14 people. Like, what is 14 people, right? But as a percentage, it's like, yeah, we're more than 50% now. So I think it kind of does illustrate the the feasibility of doing something like that. In terms of what it does for the field as a whole, I think that's going to be something like the changes I see in that are like going to be not apparent to an outsider necessarily, but I think it will make a big difference in how people do what they do. So I think that's probably just the most obvious like example of it. A couple of hobbies. Usually like a day-to-day thing. I like cooking. Like friends and partners and stuff like that make fun of me. They're just like, you just like to stir. I'm like, yeah, there's like something really meditative about putting stuff in a pot and stirring it and kind of watching it change into something that you're going to eat. So I mean, I like doing that sort of on a daily basis. I've kind of always done that. So, you know, even now I feel like I'm pretty busy, but I don't. I mean, I like food in general too, right? So yeah, I'll go out to dinner and stuff like that. But you know, I get home even if it's like 9 o'clock. I'm like, oh, I'm gonna make myself something to eat, right? Just because that process is very comforting to me. Other things. So I recently, like, I have little sort of crafty hobbies, like I put together watches. Like there's something nice about it. It's like reliable enough. You can still mess it up. Stakes are pretty low. Yeah, I mean, you got to buy parts and stuff like that, but you know, I'm a neurosurgeon. I'm not worried about like spending $80 on parts for a watch or whatever. There's like, I mean, most of my hobbies, there's like rabbit holes that you have to go down, right? So you could sit there and people talk about how they polish the hands on a watch or whatever, and you're like, yeah, at first you're like, I can't tell the difference. I don't know what they're talking about. And then you like do some stuff for a while, look at a bunch of pictures. You know, I notice people's watches now, and I'm like, oh, I wonder what that is. So there's like these little things about it that can kind of just occupy your mind, and it's entertaining. I don't know, play guitar, so like I'll mess around with that. I'm not good, so I don't practice enough and all that. But that's, you know, a different mode of sort of letting loose. My brother bought me a lathe a few years back, and so at the time I was doing more woodworking, but I, you know, like to build stuff out of wood. So, you know, those types of things. And again, I think they kind of fall into the same. Why I like surgery is like, yeah, you have stuff that you're doing with your hands, whatever. But those are, yeah, just ways to kind of distract yourself, calm down, you know, engage yourself in other ways. I mean, I've probably mentioned these things before, but like just the fact that we are able to pay attention to what we do is like something I wish more people did. Because we go through enough of life just sort of rote and like passing through. This is a funny thing. So like, how does neuroscience change it? You end up with all these little things that you like kind of pick up that have to do with neuroscience, and maybe you pay a little bit different attention to it. But the passage of time, like, you know, people say like, as you get older, time seems to go faster, right? Like, oh, why is that? And the theory is like, okay, well, once you get into a routine, you do those things, the same amount of time goes by, probably, right? But you're not paying as much attention, so the day seems to go by faster. Well, how's it a year already, right? When you're in second grade, like the difference between second and third grade is like massive, right? So people, I guess, I don't know, it's like a writer for the New Yorker or something like that. Somebody was like, oh, so I'm gonna test this out and I'm gonna pay attention to everything I do today because I'm gonna do it a little bit differently. Like, I'm not gonna do any of my routines. I'm not gonna make coffee the same way, I'm not gonna walk the same way to work or whatever. And she's talking about doing this, and she's like, I was done by 2 p.m. This was like the longest day of my life. It was a lot of hard work. I don't know what and I was just ready to be done at 2 p.m. And I think there's something to that, right? That we get really good at what we do. I mean, even my answer to that first question, like, oh, how do you deal with these stressful situations? You try to make them not stressful. How? A lot of it should be routine, right? But there's this balance of doing that and still paying attention to like what you're doing. And maybe there are some themes through this that I could put it together. But learning how to do something. Like typing right now. Pretty much everybody touch types, right? I mean, you don't see people doing this anymore. Very touch types. We have the QWERTY keyboard, which is deliberately like a crappy way to set up the keyboard. Like, they put it this way to like slow people down because typewriters used to jam, right? So if you had I think Dvorak is one of them, like, where like, oh, the most common letters are like in home row, so you don't have to move your fingers as much. The reason like the E is up there and all the vowels are in the top row and is to make your fingers have to move more to be less efficient, right? That's like a contingent thing that happened, and okay, that's how we all do it now. But everybody touch types. We're all really kind of bad at it, right? So the physical maximum speed is like maybe 150 words a minute. So maybe people train to do this, but they'll be able to type 150 words a minute. I probably type like 80 to 100, like that's most of us. It's still faster than, old Hunt and Peck, right? I've seen some people get really fast. But the reason we all type 80 to 100, even though that's like half of what you can do physically, is because once you get pretty good, you stop thinking about it, and you have all these bad habits, right? So you think about when you're typing, like, if you have to hit a number, what do? You like stop and you have to like look at which number, right? Or like, I know the Z and the X and the C, like if I will like notice, oh, that's a mistake, I'll hit backspace and I'll hit the same one, like the exact same one again, right? So all these little things that make us really inefficient at it. A lot of it is like a rote thing, like you just do it and you're like, oh, like you don't think this, right? Because you're not thinking about it. But because you're not thinking about it, you slow yourself down. If you ask people who do type 150 to 160 words a minute, how did you get there? It's like, well, I learned to touch type, I was at 80 to 100, and then in order to get to that, like, you can go to courses or whatever, like you learn to type again. And so you relearn, like, this is home row, what's under my index finger? Oh, okay, if I don't move, it's gonna be an F in my left hand, and I don't know, I have to look, it's J, right? But like explicit relearning of it, and then slowly increasing your speed, paying attention, like not letting yourself make that mistake and do it again. That sort of degree of mindfulness is how you get to be really good at that, right? And I tell my trainees this all the time for like surgical stuff, like, hey, I'm watching you close a wound, right? We do this thousands of times in our career. By the time you're sort of a mid-level resident, you've done it 1,000, hundreds of times. I watch and I'm like, okay, bad habit, bad habit, bad habit. Why are you doing this? Like, you're looking, you're like, why would you do that? And I bet if you videoed them and showed them that, they'd be like, oh yeah, why would I do that, right? But while you're doing it, you're just like, whatever. These bad habits, a lot of them come from like while you're learning it, you don't know what's gonna happen. And so you do this. So one thing is like putting a stitch in. I will watch even like the chief residents, you just see them go like this twice to put the stitch in, right? And it comes out the second time in the exact same location, but they just have this muscle memory of the first time, like, oh, that didn't go where I thought, I better correct it. And they're just so used to correcting this thing that every time they put in one stitch, they're actually doing two movements. Stuff like that, I'm like, okay. I'm a stickler for this kind of like technical stuff about how you hold tissue and move it around and stuff like that, which is kind of unusual for neurosurgeons, but like, hey, you did this, did you notice? And I harp on them about this. But you can apply this to like all sorts of stuff in your life, right? It's just like, you're not thinking about what you're doing, you just kind of go through. And yes, it could make every day the longest day of your life and kind of miserable and tiring, so you don't want to go to that extreme, right? You need to make it past 2 p.m., but there are select moments where you do that. But it's like all the same stuff that you're always doing, right? I mean, that's the point. Like, anytime you're doing something new, obviously you're paying attention to it. But where you're going to get the gains are like things that you're always doing, how you talk to other people. It's something it might sound funny to people who know me or my old junior residents, but like, yeah, there's certain ways of talking to people that at one point in time get a certain effect. You kind of get into that habit. And you're like, you really can't do that in other situations. But you're not going to notice it because you're just sarcastic, curmudgeonly. Like if I'm supposed to be trying to inspire people to be interested in neuroscience, listening to me talk about the electronic medical record being the biggest change in how we do business is probably not inspiring people, but I did that on purpose, so mindfully, intentional. But I think that type of thing, I think we just should do that more.